Good morning, everyone, or good afternoon. We are happy to host the first session on youth and HIV webinar. So welcome on board. We will be happy to ask everyone to mute their microphone while our respect are taking the lead of the conversation. Allow me first to introduce our first speaker, our keynote speaker, Professor Morenike Oluwadun Ukpong. So I hope I'm not mistaken with the spelling. Prof. Morenike has competency and experience with gender mainstreaming into policies and programs, and programming for key and vulnerable populations, including adolescents and young people. She has been a team member or lead in the design and implementation of at least 60 technical reports in the last 20 years. She had been engaged with the development of national, regional, and international strategic plans, guidelines, and documents, and has experience conducting monitoring and evaluation projects, including working on Global Fund projects. In addition, she has vast experience with conducting transnational research that has significant import for HIV prevention and the sexual and reproductive health of adolescents, and experience with research ethics and governance, including being a member of the CIOMS Working Group on Principles of Good Governance for Research Institutions. She has participated in several agenda-setting initiatives relating to HIV prevention and ethics issues, including being the chair of the ECASA 2015 Community Programs Committee, Track C Committee member of the 2016 IAS Conference, Track D co-chair for the 2018 IAS Conference, and Track E chair for the ICASA 2019-21 Conference. She has several organizational development experience, including her role as the coordinator of the new HIV vaccine and microbicide advocacy society, whose affairs she successfully steered for 16 years from its inception, member of the peer review forum, a coalition of civil society watchdogs overseeing the national HIV response, CASPR, an African coalition for organization fostering HIV prevention advocacy in Africa, and AFRNI, an African-focused civil society coalition promoting domestic resource mobilization and ethical HIV prevention research conduct in Africa. She currently works as a researcher, publisher in the institution, and one of the topmost 2% researchers in the world in 2021 by the Standard University ranking. So Professor Morenike, the floor is yours.
Thank you very much, Rehab. And it's my pleasure to welcome colleagues, youth and adolescents on this call, as well as friends and allies of the Society for AIDS in Africa. It is indeed a great pleasure to welcome all of you to today's webinar on adolescents, youth, and HIV. As you may be aware, this webinar is jointly organized by the Society for AIDS in Africa, as well as WHO Regional Office, African Regional Office. And this webinar is dedicated solely to listening and hearing the often unheard voices of adolescents and young people. Sadly, our culture and the African context are strongly held on the notion that children, and this include adolescents and young people, or people who otherwise are not married in many societies in Africa, should actually be seen and not heard in the open. This voicelessness, sadly, had had its untold impact on the HIV epidemic in the region. While the incidence of HIV is going down in many populations, it's still on the rise, albeit slowly now, for adolescents and young people. And the UNAIDS 2022 Global AIDS Update Report shows that women and girls continue to be disproportionately affected, and that adolescent girls and young women make up to 82% of people newly infected with HIV in sub-Saharan Africa. A new HIV infection occurs every 2 minutes among young women and girls aged 15 to 24 years old in 2021. In Nigeria, where I live, the 2021 report indicates that singles female sex workers, men who have sex with men, and people who inject drugs account for about 91% of all new infections among the adolescent population. Adolescents and young people, especially those living within the region, have also been severely affected by COVID-19 pandemic. A study conducted by UNAIDS in Nigeria and South Africa highlights that as high as 1 in 5 adolescents and young persons living with or without HIV have severe signs of psychological distress. About 30% of this population face violence, and 50% face increased sexual and gender-based violence since COVID-19 crisis started. And about 14% of the same population are facing sexual and gender-based violence experience on an increase since the COVID-19 pandemic started. You will notice that the panel of speakers are largely young people, supported by professional and technical resource persons from the WHO African region. We look forward to them sharing their perspective on the realities of these experiences that I've highlighted and more, and how this fits into the pictures created by the global, regional, and country data, and what more we need to do as collectives to provide the needed supportive environment for everyone to thrive. The Society for AIDS in Africa will continue to provide platforms for young people across Africa to talk about HIV, gain consensus on key issues affecting adolescents and young people in their diversity. We shall promote dialogues, including, dialogues on prevention and PrEP, negative practices, sexual and reproductive health issues such as unintended pregnancies, unsafe abortion, maternal mortality, violence, sexually transmitted infection, exploitation, sexual and gender-based violence, and discrimination based on sexual orientation and gender identity. We believe that the outcome of this webinar will be owned by young people, as well as those working with young people and policymakers, as the collective, young people would not be left behind in the global agenda of ending AIDS by 2030. I will conclude by informing participants that the Society for AIDS in Africa is committed to hosting this webinar quarterly, leading up to ICASA 2023, where a special session on the issues that emerge from these multiple webinars will be discussed. I also will take the time to acknowledge and thank every single country that has made pledges to the replenishment of the Global Fund. SAA, the Society for AIDS in Africa, will please like to encourage the Global Fund Secretariat to prioritize the access of adolescents and young people to HIV services as the subsequent rounds of the funds are issued. At this point in time, I would like to keep quiet and join you to listen to what promises to be a great webinar. Have a great webinar, everyone, and I wish you all a fruitful deliberation. Thank you.
Thank you, Professor Morenike, for your words. And as you said, that this webinar is from youth to increase their right in their sexual and reproductive rights in the matter of HIV and AIDS. So we are happy to have you all here. Please free to ask questions in the little rubric of questions and answers. Me and Aaron Sunday will be your moderators today as youth, as members from the Youth Committee of ICASA. And I'll let Aaron introduce our first speaker.
And to start off, we have Dr. Simplice Mobola Umbasi. Dr. Mobola is leading the work on adolescents and youth and health and school health in the Universal Health Coverage and Life Course Cluster at the World Health Organization Regional Office for Africa. Dr. Mobola is a medical doctor and a public health expert with over 25 years experience of working in health sector at both national and international level. He has a strong science base founded on sexual reproductive health, sexual reproductive, maternal, newborn, and adolescent health, research and epidemiology, and in-depth knowledge of public health policy, strategy formulation, and implementation. He has a long-standing network experience, frequently as senior expert and coordinator with leadership and negotiation skills, He has also a recognized experience in program development and implementation with administrative and resource mobilization and management responsibilities. Over the 25 years, Dr. Mubola developed a track record in convening and facilitating high-level events, building countries' capacities, establishing partnership, and conducting policy, dialogue, and high-level advocacy at the international and national level. Having worked in different international institutions, including UNFPA and WHO, he contributed to several researches and the development of guidelines, guidance, and also policies and strategies at the global, regional, and also country level, with a special focus on sexual, reproductive, maternal, newborn, and adolescent health. It is a pleasure to have Dr. Mubola with us, and we will open the floor for the presentation, for his presentation. Thank you very much.
Okay, thank you, Aaron. The floor is mine.
Yes, sir. Yes, sir. You can continue.
Okay. Good morning, good afternoon, good evening, everyone. As Aaron mentioned, my name is simply Mbola, not Mabola, Mbola Mbasi. I am the technical advisor working within the WHO in charge of adolescent, youth, and school health. It's my pleasure to be part of this webinar. So I have shared some slides. Maybe as the slides are in English, the presentation will be in French. I don't know if interpreters are fine with this proposal.
Yeah, it's fine. The interpreter is on. So I was saying that the slides are in English, but for more equity, I'll speak in French. So I'm pleased to be part of this webinar, and I was asked to present on HIV infections in adolescents, issues and challenges faced by the people of this age group. So I have 4 main points to discuss with you. So we'll go through quickly. First is a trend of HIV infection in adolescents and young people. And what are the issues and challenges, the opportunities, and we'll conclude. I have just 10 minutes. Next slide, please. As you are probably aware, adolescents and young people represent a growing share of people living with HIV worldwide. Statistics show that, estimates show that, from UNAIDS, show that in 2020, about 1,700,000 adolescents between 10 and 19 were living with HIV. That's about 11% of people living with HIV. It means the same estimates show that about 400,000 youths aged between 10 and 24 were newly infected with HIV, amongst whom 150,000 are adolescents between 10 and 19. In terms of mortality rate, about 32,000 adolescents die of AIDS. Next slide. This slide shows the trends. Please, can people mute their microphones, please? So as I was saying, this slide shows the trends, the progress of the infection since 2018 to 2030. And as you can see below, is region per region. Down is the East and Southern Africa region, the most infected region at this time, with a huge number of adolescents, followed by, I can say, the Central and West Africa sub-region. As you can see the trends in the various regions. Although there is a slight progress, we can only note that the number of infected adolescents in this Africa region is still very huge, and it's a call for all of us, governments, partners, and all stakeholders to do something about it. Next slide. Now, when we look at access to testing services, the situation too. Recent data indicate that only 25% of adolescent girls and 17% of adolescent boys aged between 15 and 19 in East and Southern Africa have been tested for HIV in the past 12 months and received results. And you see that this percentage is really low. The number of adolescents who have been tested for HIV is lower in the Central Africa and West Africa region compared to other regions like Asia, South Asia. With this situation, we can be bothered because in the years to come, many adolescents will be infected without even knowing their serological status, such that they would miss the opportunity to be treated. Next slide. This is the trend of HIV infection in adolescents and young people. That is at a global level and at the Africa region level. As you can see at the global level, that is the global trend, the curve is ascending, and even in the Africa region, the curve is ascending. So there is a problem at this level which needs to be addressed by all countries, by partners, and as I said, by all stakeholders, so that the prevalence in adolescents and youths should drop. Next slide. This is a number of adolescents receiving antiretroviral treatment. Compared by gender, you can see the number of adolescents is still very low. Next slide. Regarding issues and challenges, the issues and challenges in relation to HIV infection with adolescents, there are many. We can identify a number of challenges in the community and in the school milieu, because you know many youth and adolescents spend their time in school. So there are financial challenges. Sometimes there is a huge number that are unable to afford treatment because they don't have the financial means. There are challenges based on the domestic violence. Sometimes they are orphans and they live in host families, and they are not always treated with treated nicely. There are challenges related to sexual and reproductive health. For example, access to contraception, family planning. There are psychosocial support challenges, that is the lack of support, psychosocial support. Sometimes adolescents are scared, they are afraid to declare that they are HIV positive because they fear stigmatization or discriminated against. There are challenges on having treatment, and even when they can be treated, there are challenges on sticking to the treatment. So you can see on this slide, there are relationships between the various challenges such that if these challenges are not addressed properly, many youths will be left behind. Next slide. Now, to go a little in detail, the barriers to testing. Lack of confidentiality, that is, lack of access to testing sites. I talked of stigmatization, discrimination. I also talked of poverty. And sometimes the low level of education of families, the community, and sociocultural barriers. These challenges contribute to slow down access to testing services. And you know that when you don't get tested, you cannot be treated. Next slide. Now, barriers to antiretroviral treatment. In some countries, in some regions, there is the unavailability of HIV testing and services. There is the lack of services adapted to the specific needs of young people, and sometimes lack of medicines, antiretroviral drugs, and other medicines for opportunistic diseases. I equally talked of financial barriers, and I equally talked of the fear of disclosing one's HIV status. There is equally the lack of support group, lack of treatment supporters, and I would insist on the lack of education about HIV, on the infection and AIDS. Next slide.
Apologies, Dr. Simlis. We have run out of time, so
barriers related to sticking to treatment. So barriers to adherence are almost the same like those related to treatment. Next slide, please. This is very important in terms of service delivery, what should be considered, and where there could be challenges. There is integration. If you want to be efficient, there is need for integration of services. So HIV and other services. Reference decentralization of activities to offer better services in the community. Task shifting. And in the context of the COVID-19 pandemic, we should consider challenges related to service offer. Next slide to conclude, please. So, opportunities, we're running out of time. Despite the situation, there are opportunities in many countries which help to address these challenges and enable adolescents to have access to the services they need. So to conclude, I'll conclude by saying, next slide, please. I will conclude by saying, despite the number of challenges and unfavorable environments created by the COVID-19 pandemic and other health crises, efforts are made so that countries should commit themselves to ensure the well-being of adolescents, to develop and implement strategies to better tackle HIV infection in adolescents, and to support countries in providing treatments to these adolescents. So I thank you for your very kind attention. Over to you, Mr. Moderator.
Thank you very much, Angosi, please. Thank you very much. We appreciate this elaborate presentation. We'll be moving very quickly. I know there are questions coming up on the chat box. Please keep them coming. We will we'll address that during the Q&A session. So I'll move on to the next speaker. Dr. Ashley Edward Nyati is a 22-year-old engineering student at a local university in Zimbabwe. She is a peer educator and the current president of Student and Youth Working on Reproductive Health Action Team, SAA, Local Coordinating Committee. She is member of the Sexual Reproductive Health and Right SRHR Defenders and a young champion for HIV and TB in Zimbabwe. She believes in the principle of not one more, based on the background that the Southern Africa has lost too many young people, hopes, dreams, and lives due to sexual reproductive health challenges, and she stands for change. So Ashley will be sharing with us her experience from Zimbabwe context. The floor is open for you, Ashley. You have 10 minutes, please. Please keep to time. Thank you.
I'm sorry about that. I am Ashley. I'm from SAA, Zimbabwe. I'm going to give everyone the Zimbabwean experience, but first I want us all to picture ourselves mentally in Zimbabwe, so I'm going to describe the country. Let's move on to the next slide. Zimbabwe is a landlocked country in the sub-Saharan region of Southern Africa. It is in the SADC region, sharing borders with Botswana, Mozambique, Namibia, South Africa, and Zambia. So that means we have 5 border posts, and one of them is the busiest border post in Africa. That means there's a lot of truck drivers, a lot of prostitution, and so on going on. The Zimbabwean economy leans largely on mining and agriculture. The latter shall become important as the conversation rolls out. The Zimbabwean population stands at about 17 million, according to the past immediate census conducted by the government of Zimbabwe. The HIV prevalence rate in Zimbabwe is 12.9%, which corresponds to approximately 1.23 million adults in Zimbabwe living with HIV. HIV prevalence is higher amongst women than men, 15.3% in women, 10.2% in men, I think, as is the case for most countries in sub-Saharan Africa. The trend continues with generally more new cases of HIV amongst young women than in young men of the corresponding age group. Next slide, please. So that's Zimbabwe. Now, looking at HIV response in Zimbabwe, Zimbabwe has one of the world's largest epidemics of HIV. However, the country is accelerating action and increasing investment in its HIV prevention and treatment programs to reverse the situation. In 2000, a taxable income levy was introduced where 3% of taxes will be deducted to funding HIV prevention and treatment programs in the country. The levy has helped the country increase its domestic funding of Zimbabwean HIV programs by 40% and has been generally been documented as a good practice. So that's what happened in Zimbabwe. Basically, we were trying to shift from donor-aided funding for our programs in HIV programming. So the income has been used towards the Zimbabwean goal to end AIDS by 2030. The End AIDS campaign has been a long journey that can most accurately be described as a toddler learning how to walk. You know, you fall, you rise up, you think again to say, okay, what am I supposed to do to get it right this time? You take 2-3 steps, you feel like you're doing it right, and then you fall again. So we've been constantly going back to the drawing board to figure out what we are doing wrong. And life as it is has been throwing to us brand new challenges. We saw COVID, we saw natural disasters. So there's always something new that forces us back to the drawing board. Next slide, please. Now, I want us to look at the young person living with HIV. I myself am a young person, and I'm delivering this presentation from the lenses of a young person. So as young people, the most topical issue in the minds of young people is dating, relationships, desirability to our preferred gender, and everything that surrounds it. Now imagine how much more stressful it is for a young person with the same desires and wishes, but with a huge social stigma ahead of them. Stigma is unfortunately still rife and alive in Zimbabwe. Of course, there have been improvements as per the occurrence of hate crimes in our country, but the stigma is still alive. HIV disclosure is still particularly difficult and sensitive. It is still easier to tell our friends and our family that we have diabetes than it is for us to say that we have HIV, even when diabetes kills more people in my country, you know? So it's those things that affect us as young people. Stigma is still there. A young person living with HIV, society makes it immediately clear that their dating pool has been shrinked, you know? So our desirability to the next sex or gender that we are attracted to is still severely affected by our HIV status. And that is something that we have been trying to look into, but you know, societies. So, and once again, because of the social platform, it has also been very difficult for young people who have been diagnosed with HIV to accept their status, which is to say that these young people, they spend a lot of time before accepting their status and default as per their medication and do not adhere to treatment as much as they should and could. So that is still a problem. Next slide, please. Now, once again, the topical climate change. You know, in Zimbabwe, we are not sitting on the ring of fire and so on, but like I said, we are an agricultural community and we are agricultural and we are primitive. And as such, we rely heavily on our climate for things like food security. What do I mean? I mean to say that in Zimbabwe, we have a great proportion of farmers who rely on the farming practice, on agricultural practices for sustenance. What does this mean for HIV positive people in Zimbabwe? Climate change means that in the event of a drought, right, the HIV care package is advised to have nutritious food. We are supposed to have a balanced diet. But in Zimbabwe, if you remove a stable climate and rainfall, it means that the people who are supposed to have nutritious food from the farms that they are tending to no longer have that. And that is a problem. So food security relies heavily on the stability of our climate in our country. That being said, in 2019 in Zimbabwe, we had what we called Cyclone Idai. I think it was us and Mozambique, so that were mostly affected. So what happened is that we realized that there is a gap in our disaster care package. Our disaster care package does not cater for SAA services. Our disaster care packages just come with food, first aid, and things like that. So the people who are supposed to be on art, who had their pills and clinics washed away, did not have anything to depend on. And we have since been trying to get the government to include SAA services, particularly for those people whose lives depend on it. Next slide, please. Like I said before, Zimbabwe has an agenda to end AIDS by 2030. But we have a problem: intergenerational relationships. HIV prevalence remains higher in females than in males, partly owing to the socially endorsed sexually risky behaviors by males in the Zimbabwean patriarchal society. Women remain increasingly vulnerable to HIV as they comprise the greater numerical percentage of key populations, particularly in sex work. Purity culture, child marriages, and sugar daddies have a lot in common. If it is not the age gap, it is the domineering male. If it is not that, then it is the subjugation and oppression of women. Zimbabwe is in the middle of an extremely long economic crisis that has been worsened by natural disasters like floods and drought and the pandemic COVID-19. Next slide, please. Hello? Next slide, please. Okay. No, the previous slide. Okay. So Zimbabwe has witnessed a sharp rise in the culture of sugar daddies, what in the southern region they call amaplesa, which can be described as an older, wealthier male becoming intimately involved with a much younger female who will in turn receive financial support. So of course, like I said, we have a long and incessant economic crisis going on in Zimbabwe, and there has been a sharp rise in these. This one driving factor has been identified as one of the main reasons why ending AIDS by 2030 may prove difficult. These relationships help spread HIV from one generation to the other, and the patriarchal societies are enabling it, like purity culture and child marriages. Child marriages are once again intergenerational and have a strong power imbalance in terms of the young child being able to argue for safe sex and being able to access services in the event that they are infected. Next slide, please. Now, what have we done in Zimbabwe? The Zimbabwean government has been pivotal in endorsing policies that are crafted with the sexual reproductive health rights of its people in mind. Looking at the situation with child marriages, Zimbabwe has since outlawed child marriages and harmonized the sexual age of consent and the age of consent for marriages, which was a landslide victory for SRA advocates like myself in my country. And then we also recently repealed the law that criminalizes HIV transmission on the 18th of March in 2022, which was another victory, protecting and safeguarding the rights of HIV-positive persons in Zimbabwe. In terms of policymaking, we are making progress, but this patriarchal nation of ours might take time to catch up, and that is a problem. Next slide, please. Next. Okay. So just to conclude my presentation, I would just like to say, we still have a lot to do as a country in terms of HIV response. It seems as though we have focused so much on the physiological aspects of the disease and forgotten the psychological and emotional needs. When you look at the Zimbabwean platform, people have access to their contraceptives, but still the society doesn't endorse those practices. So physiologically, we're doing good. But when it comes to other aspects, the emotional aspects, the psychological, cultural aspects, I think we're lacking behind. Zimbabwe still relies heavily on donors for ARVs, which is another problem and a huge insecurity. Because, ladies and gentlemen, what happens when they remove the donor funding? It is my personal dream to one day be able to walk into a biotech lab, a genetics lab, a pharmaceutical research lab, and so forth in my country. I would like to see us take matters into our own hands, conduct our own research and experiments regarding HIV so that we safeguard our future. Thank you very much. That's the end of my presentation.
Thank you very much. Thank you very much, Ashley. This is very elaborate to also hear about what is happening in Zimbabwe with the context there. So because of time, I might not waste time. I'm introducing our next speaker for this section, Alima Gombola. Apologies if I don't pronounce the name properly. Alima is a 28-year-old human and children's rights activist. She is currently responsible for human rights at the National Council for the fight against AIDS in Senegal, where she is in charge of advocacy for the promotion and protection of rights of the most vulnerable groups affected by diseases. She is a lawyer and holds a master's degree in public international law and a master's degree in international and diplomatic relations with experience in human rights related to public health. Alima, okay, so this is about Alima. I will allow Alima. Alima will be sharing with us experience with regard to Senegal, Dakar. So Alima, the floor is yours, please. Thank you very much.
Bonjour tout le monde. Good morning, everyone. Thank you for giving me the floor and giving me the opportunity to share this experience from Senegal. Quickly, we are now going to look at the background and the epidemiological background in Senegal. Next slide, please. In Senegal, the HIV AIDS epidemiology is dropping. We have a prevalence rate of 0.3. Previously, it was 0.5, but now it is 0.3%. The prevalence is higher amongst women than amongst men. And the disease has been feminized. There are about 4,000 children over the past few years who have been tested positive for HIV. And looking from 0 to 14 years, we can see the rate over there, the national population prevalence over there. Next slide, please. Now, the peculiar thing amongst the youth is the new infections. 4 out of new infections occur before the age of 25. 22.2% involve those from the age range of 0 to 4 years, and then 14.3% concern those from 15 to 24 years. Talking about the new infections between 2018 to 2022, there has been a 3% increase amongst the young people. There's been also an increase amongst MSMs, that is men having sex with men, and then key populations. We have about 79% of these new infections occurring amongst the MSMs. The new infections also cover about 42% of young women from 15 to 49 years. Next slide, please. several factors are responsible for this. The first has to do with the poor level of knowledge about HIV and STIs, as well as their methods of preventing them. From a study conducted in 2017, it is known that only about 31.5% of young ladies aged between 15 to 24%, and then 12% of young boys have access to HIV screening. Also, early sexuality. A lot of young people start having sex before the age of 18. And also, only 31.5% of young ladies have access to HIV screening. There's an ongoing study to update the results that we have, but since 2017, the rate of access to screening services is very low for young people. As I said earlier on, there's early sexuality, and then the phenomenon of having multiple sexual partners, and then having sex with older people who have HIV infections, and then early marriages, poor access to condoms. Condoms are supposed to be free, but then those who distribute these condoms, they kind of look down on these young people who try to get access to them. So it prevents them from trying to access these condoms. And then there's sex work amongst young girls, drug consumption, which is high amongst the Senegalese youth of today. The next factor is poverty. Then at the legal front, the legal age for voluntary screening is 15. So it's hard to get to screen street children or those who are not in formalized home structures. Next slide, please. There are several challenges that we face, but then the biggest has to do with communication challenges and sensitization. So the biggest challenge that we are facing is adaptive communication. Communication that is tailored to the youth and then the adolescents. We have realized that our communication strategies are not really tailored to reach these young people and adolescents, and we are trying to correct that today. So we would like to also make use of social media, increasing the knowledge of young people and adolescents on their disease and on issues of sexual and reproductive health, human rights, and then gender. More and more young people are asking questions on these issues, and we are trying to get them to be at ease with them. We have challenges that are related to screening as well. The legal voluntary age for screening is 15. And so adolescents who are younger than 15 cannot go and get the screening. But then in Senegal, we have illiterate children who have not been to school, who are street children, who are orphans, and who might have been abandoned by their families, and they are highly vulnerable. They live in the streets, they get involved in sexual practices and in drug consumption. They are highly vulnerable, but then we do not have access to them because of the legal framework for screening. Next slide, please. We have several perspectives. that's on the way forward. I just have 3 over here. One is to have strong political will and partnerships. We have partnerships and agreements that have been signed with bodies such as the Ministry of Youth, the Ministry of Education, the Ministry for Family Planning, UNICEF, ADCME, that is the Directorate for Mother and Child Health. We are also looking at pediatrics. Through these partnerships, we have come up with the all-in strategy with UNICEF, and this seeks to put an end to the pandemic of HIV amongst youth and adolescents by 2030. And this slide. So this strategy makes it possible to strengthen decision making and in fighting HIV, and this strategy is being implemented now. This year, we have been able to reach a wider range of young people.
Alima, can you try and be rounding up?
That is the National Health Day. Yes, I'm going to conclude. I'll give the example of the National Health Day that we organized this year in Senegal. The theme was to put an end to inequalities. Next slide. We organized mini panels in public schools, in private schools, in high schools, in colleges as well. And we try to sensitize the young people about HIV issues. And there were many panel discussions over there. Next slide. So we organized these panels on the D-Day, and these panels were made up of young people, and the target was young people with the goal of talking to them about the disease based on 4 themes. That is knowledge and attitude of youth, the fight against discrimination, putting an end to inequalities, and then AIDS-free generation. What can the youth do in this fight? Next slide. And these are the outcomes. They were very comprehensive. We had more youth getting involved from 44 associations, organizations, schools, and colleges. They participated and they were sensitized to know about these things. 3 weeks prior to this, they had no knowledge, but after this, they were able to be educated on that. We had volunteers also, and they are also sharing this experience in their families and in their social circles and school circles. So we came up with a program that we are implementing in Senegal for these youth, and then by the youth. They are implementing this program themselves. We had some girls who came to share their experiences with us, and this helped to raise awareness amongst their peers on this illness. Next slide. So I just shared with you the Senegalese experience on this disease. We are facing challenges, certainly, but we are just doing our best to address these challenges for the youth. Thank you very much.
Thank you very much, Alima. Thank you very much for that elaborate presentation. So I know we are behind schedule with time, but however, we'll also allow our panelists, before you drop out, there are some few questions on the Q&A that has to do with each of your presentation, which I appreciate. You help us in terms of responding. So starting with the first presentation, the question here is saying, what programs that work in other countries that is doing well in curbing new HIV infections, except DREAMS, which is a global program. So I think this question might be tailored toward Dr. Simplis. Probably I want you to take note of this so that you respond to it. Then the second question here we have, in South Africa, we are leading on HIV infection among adolescents in sub-Saharan Africa. And ending HIV is far-fetched as we are engulfed by inequality and as well as poverty. And while this one seems to be more of a statement, I will appreciate my Francophone colleagues to look into the Q&A because I know some of the questions were written in Spanish, and in French, I mean. Then we have a question, how can civil society organization working with adolescents and young people deal with financial challenges that our target groups, young people live with HIV, sexual active and young breadwinners or sex workers are faced with? So this is from Festus, Liberia, either Dr. Simplis or my sister from Zimbabwe. You can take this up. And then we also have tax shifting mentioned in the first presentation. What types of tax are thought to be more suitable in the mid-level providers and community health workers? And what research is still needed on tax shifting? So I'm going to stop here, but I'm sure that our speakers are here. They can respond to most of these questions by typing and responding to them. So I'm going to give 2 minutes each to each of our speakers, as the question implies, for you to be able to respond. However, I think there is still a question for you, Aline. Though it's written in French. So colleagues, I appreciate you have read the French questions here. Thank you very much. But I think we can start with Dr. Simplis. Can you respond to a few of these questions that has to do with your presentation? 2 minutes, please. Thank you.
OK, merci. Je crois que...
Thank you. I think you noted two important questions, that is, the involvement of adolescents in AIDS control. As far as I know, there are adolescents and young people should be involved, strongly involved in developing programs, that is, implementing these programs and monitoring evaluation of these programs. Should not wait for them to be beneficiaries. They should be actors. In this region, there are many initiatives led by the youths. For example, AFRIAN, which is doing a lot in providing sexual and reproductive health services, including contraceptives, family planning, and access to screening, testing, and treatment. So for me, the youth should be involved. For that to happen, they need to be equipped in terms of knowledge and for them to be effective. They are better placed to talk to other youths compared to we, the elderly people, because when they have capacity, they are better placed to talk to other youths, and they are better placed to be frontline actors. So what I would advise is that the youth should document what they are being done, and it should be shared with other youth from other countries, especially success stories.
All right. Thank you very much.
It should be shared with other people, other youths in the continent. So the questions in French, maybe I will just have a look, and if the moderator permits, I can answer them.
I will suggest that some of the feedback will be given directly on the chat box because of time. I understand we are already behind schedule. So I will appreciate if you can also respond to some of the questions that has to do with your presentation via the Q&A session. Because I know there's a question on tax shifting. There's also a question about resources for young people. So I will hear from Alan, and then also hear from my sister from Zimbabwe regarding the question. 1 minute, please, so that we move over to the next session and have my colleague Rehab take over. Thank you. So.
Hello again.
Yeah.
Allô? Oui. Je vais répondre rapidement à la question qui
I will
est...
answer quickly the question.
Je peux?
May I continue?
Of course. Okay, thank you.
Yes, please. 1 minute, please. Just very briefly, because you're already behind.
Okay, thank you. D'accord. Je vais répondre rapidement à la question qui est plus une...
So I'll quickly answer the question, which is more of a contribution than a question. You talked of the legal testing age for youth below 15. They should have their parental consent. It's true that in Senegal, we are trying to review with members of parliament. We've had sessions with members of parliament for us to try to review this, to see how to lift this barrier and see how to reach out to these children with whom the legal age is a problem. So it's on course with members of parliament from Senegal. There is a new law that is being prepared and activities towards this are planned. Thank you very much.
All right, thank you very much. So Ria, over to you, please.
So again, on behalf of the organizing committee, we're happy that you are still with us and yeah, that we are we will be tackling sexual reproductive health and rights services and sexual gender-based services. So our first speaker is Dr. Shilanga Sani, who is a public health specialist with training in medicine and medical anthropology with an extensive experience with national and international organizations working in the frame of sexual and reproductive rights. So let me remind, before offering the floor to Dr. Shilanga Asmani, that all our beloved speakers should be respecting the time allowed because we are behind schedule. And feel free to ask the questions in the question and answers box or in the chat. So Dr. Shilanga Asmani, the floor is yours.
Thank you very much, colleagues. I hope you can hear me. And I will take a few minutes to give a bit of an overview on sexual and reproductive health and rights in the Africa region. And then our young experts will give us really, bring it down to the country level to see what's happening at country level. So we'll also have that rich experience from the country from our young experts who follow my presentation. It will be really an overview. But as we look at the overview, we'll actually see where we have the SRHR overview, we see how and what specific issues that impact adolescents and young people. And I hope from this, we'll see that it's key and very important to address the SRHR needs of adolescents and young people to be able to contribute to the overall improvements in the SRHR situation in the region. Next. Just as a quick snapshot, I just want to remind all of us that when you do talk about sexual and reproductive health, we talk about a number of elements which you should take into account. And if you look at what we have on this slide, they all impact young people, adolescents in different ways, and they all need to be addressed in different ways to suit the needs and to respond to their needs as young as young people, adolescents. So I think this is a snapshot for us to remember what do we mean when we talk about sexual reproductive health and rights. Next. Also, it's important that to look that at the end, we are talking about a bigger picture of how do we reduce maternal mortality. And over years, we've seen that the number has reduced, as we see on the slide. But in spite of this, there are still regional inequalities. Even within countries, there are different inequalities in progress. And unfortunately, in the sub-Saharan Africa and in South Asia, these two regions account almost 86% of all maternal deaths in 2017. So it's really a challenge for these two regions. And one of them, of course, is our own sub-Saharan Africa. Next. So this slide will also show that we have seen reductions in maternal mortality between 2010, 2017, which is positive. But also, key here is also to show that what has caused this, there's obviously some high impact health services, as noted there, antenatal care, skilled attendance at delivery, postnatal care. But more importantly, as even some of the previous colleagues talked about, we also need to see that improvement in social determinants such as gender inequalities, geographical barriers, and other social determinants are key and important to change this picture. Next. Looking again at some of, again, talking to maternal deaths, we see a number of causes inside the circle and their percentage. But we also see in the boxes around the circle some of the interventions that could actually help us to reduce this challenge. We see it, and a number of them are related to
Dr. Asmani, I'm sorry to interrupt, but can you please raise your voice so everyone can hear you, please?
Okay, the voice is not loud enough. Is it better now?
It's a nice smooth voice, but you should maybe raise it a bit so everyone can listen.
Okay, I'll try to raise a bit. And just to say that the boxes, as we see around the circle, represent some interventions that can help reduce maternal deaths. And a number of them are related to sexual reproductive health services. So this is also key to show the importance of sexual reproductive health for the bigger picture. Next. Another important, though sensitive, is how unsafe abortions also contribute to maternal mortality. 16% of deaths are related to unsafe abortion. And for us to respond, we need to look at the laws. We need to increase access to family planning, and need to improve access to post-abortion care services, all of which could be a challenge, but need to be addressed in order to respond to deaths. Next, the contraceptive prevalence rate shows continues to be low. It was stagnated at around 23% since 2017. And we see that the proportion of women whose family planning needs are satisfied has shown some increase. And it's important to note that if we're able to increase access to contraception, it could also increase, at least help to reduce the maternal mortality even by a third worldwide. So another important SRHR service. Next. FGM, female genital mutilation, another challenge. This picture shows us the situation for girls 15 to 49 in the Africa region. And obviously this impacts those from the young age up to older women. And we still need to do a lot. As we see in some countries, the prevalence can be below 10 or single digits, but in some countries can be as high as 90 to 95%, which is a very high rate. And how do we do this? We need to increase efforts of our governments, international community and donors in terms of mobilizing resources, but also to enact and enforce laws and national policies that could help reduce this situation. Next. Sexual and gender-based violence, I think colleagues have mentioned in their previous response, in the previous presentations, that it is higher among vulnerable populations, including girls, adolescents, women and children, the elderly, and of course, This impacts not only on their sexual health, impacts on STIs, HIV prevalence, as has been mentioned, and there's a wide range of gender-based violence that we can talk about. But the graph also shows that while some countries the proportion is low, but in certain level, in other countries, the prevalence is very high in terms of intimate partner violence. And again, our young people and adolescents are highly impacted by this and have therefore impact on their sexual reproductive health and rights and overall health and well-being. Next. Cervical cancer, which is the fourth most common cancer in women, 604,000 new cases, 342,000 deaths in 2020, which is very high. And of course, it's important to note that almost 100% are linked to HPV infections, therefore sexual transmission. The proportion of women who are screened is still low at around 50%. Those that are able to access HPV vaccine, which is again our children and young adults and young youth and adolescent age group, it's still low. Countries are not able to have this in their schedule of immunizations. The percentage of girls under 15 who have received the full course of HPV vaccine was around at 19% in 2020. So still a big challenge for the needs of our adolescents and young people. Next. Toning down again some specifics on young people's adolescent and youth SRHR, we see how the contraceptive prevalence continues to be low at the African region, around 17% as an average, but countries, as we see, majority are even below the regional average. And if we go to the next the slide, please, next slide, we'll see that there's a relationship between the low contraceptive prevalence and the proportion of young adolescents who have begun childbearing. You could actually see where there's lack of access to family planning. The impact is also on adolescent pregnancy, which also has impact on their sexual reproductive health, their rights, and other STIs and HIV infections. Next. So we actually see that as young people pass through puberty, their needs are many in terms of sexual reproductive health and rights. The proportion of young women who are married at 2024 continues to be high, and linked to that, as our colleagues have mentioned, there's a link to how the HIV infection impacts adolescents aged 15 to 19. And we've seen from the different experiences and presentations from countries, it's impacting more adolescent girls than adolescent boys. Next. Again, still a lot needs to be done in order to meet the sexual and reproductive health needs of adolescents and young people to help us fulfill their rights. We need to have adolescent-friendly services. We need to address harmful social norms. And important to note is that we need to invest in adolescent sexual and reproductive health, because this may delay first pregnancies, reduce maternal mortality, improve overall health outcomes, and of course, contribute to other broader development goals and reduce poverty. Next. So some key messages we need to note is adolescence is a time of rapid change. It's a window, we say a second window of opportunity, where we can build on the lacks and the gaps during childhood. It's a time when we can actually catch up and improve the health of our adolescents and young people. Gender issues have to be taken throughout as important aspect to SRHR. Next. We also have to ensure that as we work on our SDGs, we don't leave adolescents behind. They are part and parcel of coming up to meet our SDG targets. We need to strengthen implementation of innovative programs. I think it has been mentioned how we provide services, for example, task sharing, self-care, involvement and engagement in young people in offering services. But important, we need to show how to integrate SRHR and HIV services to give holistic, comprehensive services, living and meeting all of their needs. We need to ensure that we address inequalities within and between countries. We need data for advocacy and decision making. So we're using evidence. But what is also important, as we said, is not only a health issue. We need multi-sectoral engagement, comprehensive approach, and address sociocultural dynamics. These are not just barriers, but also sociocultural dynamics means we have opportunities using our own sociocultural context to actually address the needs and take all of this into account as we design and implement programs for adolescents and young people. Next. So this is just a snapshot. I hope that as we hear our young experts with the country experiences, we'll be able to really see the status in country and help us together design, implement, but work together to monitor and report progress. Thank you very much.
Thank you, Dr. Asmani from WHO Regional Office for Africa for your extensive presentation, and I hope everyone is benefiting. So please feel free to ask questions in the box or in the chat. Our next guest is Doreen Moracha. Please correct me if I'm pronouncing it wrong. So Doreen is a young woman living with HIV from Kenya. She is the founder of I Am Beautiful Story Digital Initiative, and she is very active in the field of sexual reproductive rights in Kenya. So Doreen will be talking about sexual reproductive health and rights services and sexual gender-based violence experience from Kenya. So Doreen, please, the floor is yours.
Thank you so much, Rehab, and thank you for giving me the chance to be here this evening. Good day, everyone. My name is Doreen Moracha, as I've been introduced, and I'm going to speak about the sexual reproductive health and rights services and gender-based violence experience from the Kenyan perspective. Before I get into my presentation, I want to share with you some two lived experiences. A story is told of a young girl who was 9 years old, or rather, I think she's 10 now, and she was attending a sex education session. And when they were talking about sex and the facilitator asked about sex, the girl was confused and asked the older ones, what is sex? Because she was the youngest in the room. And the older girls were giggling and told her what it was. Then she went ahead and told them, my cousin and my brother do that to me. I told my grandmother, but she told me not to ever tell anyone. And of course, that left the facilitator very shocked, and she did a follow-up after that. The second experience is from a young girl in Kilifi County. This girl was 11 years old, and she went to a health facility. Kilifi County is one of the counties with the highest number of teen pregnancies in our country. And she was asking for a family planning method. She was 11, and the nurse told her she cannot be able to give her access to a family planning method because she is a child. So she told her, if I come back here pregnant, don't blame me. So she went. A few months later, she came back in. She was pregnant. She now wanted an abortion, of which still she could not get. And she went back home. And of course, you know, just because abortion is illegal does not mean that it cannot be accessed. So she accessed an abortion, an illegal abortion that was done in a funny clinic, and she bled to death. So she was actually taken to the facility where she sought the information first, the services again, but still never got them because she was 11 years old. So she bled to death at the clinic, and yeah, now she's gone. So in Kenya, almost 1 out of 4 women give birth by the age of 18, and nearly half by the age of 20. 1 in every 5 adolescents aged 15 to 19 are already mothers or pregnant with their first child. The Kenya, sorry, just a minute. Okay, sorry. So the KDHIS 2014 survey says in 2021, the country recorded a total of 316,187 adolescent pregnancies. Of this, 294,364 pregnancies were among girls aged 15 to 19, while those aged 10 to 14 contributed to 21,823, which is like 7% of the total adolescent pregnancies. This has led to us being ranked as the third country worldwide when it comes to teen pregnancies. According to the National AIDS Control Council in Kenya, between January and February 2022, we have recorded 45,724 cases of teen pregnancies. This has actually led the National AIDS Control Council in Kenya to come up with a campaign called the Triple Threat to address sexual gender-based violence, new HIV infections, as well as teen pregnancies. These numbers have been contributed largely by limited access to accurate information you can see that from the two lived experiences that I started with, and also a lack of access to limited accurate information on sexual reproductive health, as well as early sexual debut and defilement cases. The data I have just read only captures adolescents that went to hospital for antenatal care. Adolescents and young people majorly fall prey to myths and misconceptions around sexual intercourse. For example, they say that if one does not have breasts, then you cannot get pregnant. That is why we have a young girl of 10 years old becoming pregnant. They also say that if one has sex and cleans their private part with the Coca-Cola soda and lemon, they will also not get pregnant. As well as some myth that says that if young people have said that if you have sex while you're standing up, you can also not become pregnant. But as we can look at from the numbers, those are not just numbers. Those are young girls. Those are adolescents and young girls in all their diversities. When you go to the issues of gender-based violence, which is actually very prevalent in Kenya, according to the Kenya Demographic and Health Survey report of 2014, 45% of women aged 15 to 19 had experienced physical violence, and 20% had experienced physical violence within 12 months prior to the survey, compared to 39% and 24% respectively in 2008. The Kenya Demographic and Health Survey report of 2014 further estimated that 44% of men aged 15 to 49 experienced physical violence, and 12% experienced physical violence within the 12 months prior to this particular survey. When it comes to the Triple Threat, which is a campaign that addresses specifically sexual gender-based violence, in Kenya, just like the rest of the world, SGBV is complex. And the women and girls, and even boys, and adolescents and young people in all their diversity who experience violence rarely report the cases, especially if the perpetrator is a family member or a respected individual in the community. Many at times, the cases are settled out of court, and the person that solves the case is the chief, where the perpetrator is requested to pay the family members either cash or give the family a cow or goat, thereby denying the survivor access to justice. In the northern part of Kenya, most of the young girls are sexually abused by very close relatives, but this always gets settled by a kangaroo court. And the girl is either married at a very early age, or they are exchanged with some livestock here and there, and the perpetrator gets to walk away freely. The policy environment in Kenya is one of the huge gaps that we have. And it's very concerning, especially when it comes to adolescents and young people's sexual reproductive health. Recently, Kenya launched the National Reproductive Health Policy 2022-2032, which states that adolescents and young people below the age of 21 will require parental consent to access sexual reproductive health services without taking into account the evolving capacities for adolescents. Some of the challenges that can be seen from the Kenyan context, lack of access to information and services surrounding sexual reproductive health and rights. We have the issue of cultural and social barriers. We have the structural barriers where most of the healthcare providers, their hands are tied and they're not able to give either information or services to adolescents and young people in all their diversity. We also have the issue of unaffordability. For example, the issue of the 11-year-old who was unable to get an abortion when she sought for one, had to resort to a clinic where she could afford, but that led to actually her dying. We also have barriers to access to remedies by survivors of sexual violence because their mental health is not taken into account. Most of them don't go to hospitals and most of them don't even report that they have been sexually violated. There is lack of awareness of services that exists. Most of the survivors of sexual violence don't know that there are services that actually exist when you have become survivor, or rather you have been abused sexually. And that is one of the things that we really, really need to focus on. There is also the burdensome and humiliating justice system. The shame of reporting on matters sexual gender-based violence has made many survivors turn their backs away and not go to report because nobody wants to stand in a judicial system where they are being questioned on something that is actually affecting them both physically and mentally. We have seen very many campaigns in our country and very nice policies. The only issue comes when it comes to implementation. And Kenya has made significant investments to ensure adolescents and young people.
To interrupt. But can you please round up so we have enough room for questions later?
Okay, I'm be done in the next 2 minutes. So Kenya has made significant investments to ensure adolescents and young people are educated to enjoy a healthy life and attain the aspiration. New HIV infections, adolescent pregnancies, and sexual and gender-based violence threatens this progress. So how can we do right by adolescents and young people? We have to ensure that we have better policies that will have a direct impact on access to sexual reproductive health for adolescents and young people. The government of Kenya specifically should develop policies that reflect the lived realities for adolescents and young people. We can't run away from the aspect of age-appropriate comprehensive sexuality. We must nurture adolescents and young people in their diversities into good and proper sexual choices. And I personally stand for comprehensive sexuality education inclusion in the curriculum. Let us open our eyes to the gaps, address them accordingly, and bring adolescents and young people to the table to speak on their issues as well as to get practical solution. And according to the commitment Kenya made at the ICPD 25, we need to end maternal deaths, unmet needs for family planning, and zero gender-based violence. I hope that the reproductive health policy will create an enabling environment to realize these 3 zeros by 2030. As I finish by Dr. Natalia Kanem's quote that says, "Together with the young people of this planet, there is nothing we cannot overcome." Thank you so much.
Thank you, Doreen, for your intervention. Our last speaker today will be Fatoumata Kontao. She's 26 years old. She's married and a mother, and she is currently the president of the peer educators of CISAC de BKO. She's a member of the board of directors of the Arcade Santé Plus and member of coordination for the Grandir Ensemble network. So, Fatoumata, vous pouvez maintenant parler.
Fatimata, you may take the floor now. Thank you for giving me the floor. Good day, everyone. I apologize for not turning on my camera. I'm having some internet connectivity challenges. Next slide. Thank you for this opportunity that you have given me to speak in this webinar. This is the outline of my presentation. I'm not going to talk figures. I'll just focus on real facts. And then the real experiences of the youth in Mali. Next slide. A few definitions to ensure that we're on the same page. Sexual health has been defined by WHO, and we are all aware of this definition. And for the youth, I would like to say that I'm focusing on youth from puberty to adult.
Vous m'entendez?
Can you hear me? Okay. We cannot hear you, Fatoumata.
Je vais m'accentuer sur la population
I'll
générale.
look at the targets for the Malian case. I'll look at the general population, the key population, and then the youth.
Qui est séronégatif.
Fatoumata, we are sorry to interrupt, but we can barely hear you. Now, so for the key population, I'm referring to the LGBTQ population. Next slide. No. When we talk about sexual health, we can also talk about needs, because sex is a taboo issue in Mali, and we youth have poor access to sexual health services. The centers are not suitable for the young people, or the health workers are not as trained as they must be, given the kind of reception that they give to these young people. Sexual education in schools is incomplete. So from the youth who are 13 to 15 years and who are sexually active, well, they cannot get access to screening, and without parental approval, they can only get access to screening when they get to the age of 18. A lot of young people are sexually active, but then they cannot get screened without prior parental approval. Next slide. There's a supply of contraceptives for treating STIs in these centers. There's a low supply. Sometimes of course, you have the gynecological departments in these sexual reproductive health centers, but then they do not have the contraceptive supplies over there. And so it's hard for the youth to get access to that. And then certain youth refuse to go elsewhere in order to avoid complicating their situations. Now, the challenges. So when we talk about sexual health, we are also talking about challenges, especially for the youth. One of the previous speakers mentioned this, that when you are young and you are not married, you'll face certain challenges. And so there's the issue of stigmatization and then discrimination for all the target populations that I spoke about earlier on. If you are young and you go to a pharmacy to buy just condoms, well, the boys have it easier than the girls do. But that is a whole challenge on its own. You are asked, you are a young unmarried girl, what are you going to do with a condom? And even the boys are asked threateningly, what exactly are you going to do with these condoms? So it's hard for the youth to go there. And then there's the future criminalization of homosexuality in Mali. Homosexuality is not really accepted in Mali, and so it will be criminalized in future. And we'll see how they go about this. And this makes it hard to follow up on, monitor these young people. Next, there's poor knowledge. If a young person is trying to get more knowledge on their sexuality, it's like people are afraid to get closer to them since they are HIV positive. They are scared that they are going to get the disease from these young people just by contact, which is not the case. The young people do not know where these centers are. Furthermore, they do not even know where to go to get advice. Next slide. In conclusion, I would say that as a young peer educator who is working in a lot of associations, we have come up with many awareness raising campaigns for the young people online so that we can send the messages across to them on positive methods of stopping HIV/AIDS transmission amongst young people. Without being gross in my speech, I think we need to, our politicians need to, and our policymakers need to be open-minded in order to put a stop to HIV/AIDS by 2030. Thank you for giving me the floor once again.
Merci bien, Fatoumata, pour votre présentation.
Thank you very much, Fatoumata, for your presentation.
The guests of the second part of the webinar, Dr. Asmani, Doreen, and Fatoumata. The floor is to participants for the questions. So please feel free to ask any question you want. We are already having two related to the second part of the webinar. So one is from Geraldine asking about the implications of parental consent in HIV treatment. The second is from Samuel asking about which interventional measures should be taken to enhance young men and boys' access to services that are about gender-based violence and sexual based violence, and their guests would take the floor and answer any of those two questions. Please feel free.
I'll take the question on how the Children Act was amended to introduce a clause that requires children to get parental consent in order to get reproductive health services. That will affect access to SRH in two ways, both the positive and the negative. The positive in that now the sexual reproductive health and rights conversation starts from home, because that is a conversation that is not being held at home. It has been thrown to teachers in school, and there has been an issue with talking about SRH in schools as well. And CSOs are pushing for the inclusivity of age-appropriate sex education in schools. So if the conversation starts at home, the parent realizes the need for their child, for their adolescent, to get the services, to get the information before even going to school. And on the negative perspective, on the positive perspective as well, the parent helps the child get the information they need, get the service they need, as long as they're within the age to get whatever services that they want. But when it comes to the negative effect, it's because one children can always go behind the parent's back and get another adult to stand in at the parent. That means lying to their parent. And also there is that lack of openness at home in having these particular conversations. So as much as it is a good thing to get the parental consent, there is also the other side where in order to get a reproductive health service and you need a parent and you don't talk to a parent and the conversation is not happening at home, then it's either you are lacking both the information and the service as well, or you are using a third party to get to access the information and the services, and that does not always have the desired result, because sometimes the third party can take advantage of this particular child or of this particular adolescent and young person trying to access the services and the information that they need. Thank you, and over.
Thank you. Thank you very much for your answer. And if one of the guests should be taking the floor to answer any of the other questions, please.
Yes, I could answer one of them, or at least give my comments. Maybe others could add. I think it was a very important question on really ensuring services for young men and boys, as it is in terms of sexual gender-based violence. Maybe what I can say, as per my presentation, it also goes around the importance of addressing the social cultural dynamics, because even when it comes to gender relations, gender-based violence, and how adolescent young people grow up, there are certain aspects which touch on men or boys and others on girls. So on the part of men, we know how they are brought up, maybe what a boy can do, what a boy cannot do. And so it's important also to address this aspect for them also to have positive, I would say, behaviors as related to sexual and gender-based violence, also to be able, even as boys and young men, to report, though it's a challenge for them to report if they are the ones who are actually the ones abused and therefore need services. And again, I think as the young experts talked about, the importance of involvement of these young men and boys, young women and girls, from the design of the services and information they need to the implementation and follow-up, so that it's really geared to their needs. So I think this is one way we could look at how we could ensure access to services for both young men and boys in terms of sexual and gender-based violence. That's what I'd just like to add as it relates to the question on young men and boys' access to SGBV services. Thank you.
Feel free. Thank you, Doctor. So, une dernière question pour Fatoumata. Donc,
one last question for Fatoumata. Since you are a peer educator and a head of an association of peer educators, what do you think of this kind of education in promoting sexual and reproductive health services for adolescents and young people?
I think we have lost Fatoumata, so I'll invite Aaron to show up again and to provide the closing remarks for the audience. So Aaron, please.
All right, thank you very much. Thank you very much to all the speakers. We sincerely appreciate you. It takes a commitment towards adolescent health, whether within the context of HIV or sexual reproductive health, for each and every one of you to avail themselves these afternoons or this morning in your respective time zone. We want to use this moment to appreciate the leadership of Society for AIDS in Africa, SAA. We also want to appreciate WHO Africa Regional Office for putting in this excellent webinar, which has helped us to deep dive into the situations of adolescents, whether in the context of HIV and also sexual reproductive health, within the context of also looking at the technical and as well as the community perspective. We sincerely appreciate our own also participants it's not easy for you to have also blocked your time to make sure you don't miss this amazing webinar. We want to appreciate you, and we hope that the learning that we take in from today, especially the best practices that were shared across what is done in different countries, it's something worthy of emulating. For instance, if Zimbabwe have moved to a point of saying 3% tax and have already achieved 40% increase in financing HIV programming, it's something worthy of scaling. We also appreciate all our technical WHO for all the work you've been doing. At this point, I will wish us all the very best, and then I'm sure we will have more of this webinar and more of this conversation. Thank you very much.
Thank you very much for your attendance to the webinar. This is the first initiative to talk about HIV and adolescent and young people. So thank you for being there and for committing with us. Our second part of the session was mainly about how youth-friendly services should be adequate, inclusive, and we have learned from all the good practices in Kenya and in Mali and experiences from across Africa region. So we from each other through anchors. So thank you again, Dr. Your input was really inspiring. So this is just the first experience. We hope to see you in webinars. The society provide a platform for young people across on the key issues, including for other. And it was a pleasure moderating this session with you, Aaron. So
thank you very much, Ria. I think Dr. Mark is also online. So probably Dr. Amen, probably you can also give 1 or 2 words to our panelists and as well as the participants before the link goes up. Thank you. Over.
Okay, thank you so much. I would like to thank all the panelists and especially those ones that are listening to us across the region and across Africa. You know, what is more important is that we just apply what we just learned today, and we make sure that we continue having this webinar, you know, on regular basis, especially once every quarters. And we believe that without the youth, there is no future, there is no development. Thank you so much, and see you soon at ICASA 2023. Thank you.